Antiphospholipid syndrome is often thought of as thrombosis alone. So APS often reduced to DVT, stroke, and pregnancy loss. But antiphospholipid syndrome is not just a clotting disorder. It is a systemic vascular disease. Understanding the non-thrombotic manifestation is crucial for early recognition and prevention of damage. So the first principle, APS is a disease of endothelium. APS is a disease of platelets. APS is a disease of microcirculation. So damages may occur even without overt thrombosis like DVT or arterial thrombosis. Let's see the hematological manifestation of APS. It's one of the earliest clue. Mechanism of each of these manifestations will be discussed. For example, thrombocytopenia is common, it's immune mediated. Hemolytic anemia is common, it is Coombs positive. Leukopenia is common, it is autoimmune. So mild thrombocytopenia in APS is common, but that does not protect against thrombosis, the paradox. Coming to cardiac involvement, APS can affect heart valves. Liebman sac endocarditis. It's a non-infective agitation with mitral more involved than the aortic, and it can rarely embolize and produce an embolic stroke, often mistaken as infective endocarditis. Coming to non-thrombotic neurological features of APS are cognitive dysfunction, recurrent migraine, seizures, and movement disorders like chorea. These may occur even without infarction. So it's likely due to microcirculatory dysfunction. So that's why we don't see infarcts in the MRI. Coming to renal APS, microangiopathy may present as hypertension, proteinuria, and mild renal impairment. Not always the classical renal vein thrombosis the textbook describes. And biopsy shows thrombotic microangiopathy. This is renal APS. Dermatological clues can be there. Skin may reveal early APS, lividoreticularis due to microvascular disease, skin ulcers due to ischemia, and digital ulcers due to small vessel involvement can happen. Livido may be a major bedside clue as to the patient is having an APS. And of course, there is the dangerous obstetric APS. Beyond miscarriage, it is associated with preeclampsia, IUGR, placental insufficiency, and preterm birth. It is basically due to the placental vascular pathology that drives this disease and lead on to these complications as well as fetal loss. Pulmonary involvement, APS can cause pulmonary hypertension, diffuse cellular hemorrhage, one of the dangerous complications due to vascular pathology rather than embolism alone. And never forget the catastrophic APS, of which we have done another video, but we'll just briefly discuss here. It's an extreme systemic microthrombosis, multi-organ failure, ARDS, AKA, encephalopathy altogether occurring within a few days or simultaneously. And this is often triggered by infection, and then sepsis is one of the commonest differential diagnoses. Surgery, pregnancy can also precipitate this. Now, what are the laboratory clues? Beyond the clotting events that happen in APS, look for persistent of antiphospholipid antibodies, not a single positivity. Look for persistent thrombocytopenia, look for a prolonged APTT. A prolonged APTT in APS is not equivalent to a bleeding risk. It reflects lupus anticoagulant that is interfering. Now let's see the brief clinical pattern recognition. Suspect APS even without thrombosis when you see livido with thrombocytopenia. When you see a patient with new valve disease with a stroke. When you see a patient with unexplained pulmonary hypertension. When there are recurrent pregnancy complications, even when the miscarriage is not there, or a TMA like renal disease, thrombotic microangiopathy like renal disease. So APS is not just a disease of clot forming, it is a disease of dysfunctional endothelium and microvasculature, which need long-term treatment.